right, so today I'm going to try to talk to you about the HOPES group, the Health Outcomes Policy and Evidence Synthesis group, and how we are the hamburger helper of the healthcare system. So as you can see, there's more to see than can ever be seen and more to do than can ever be done. And that is especially true for today's very busy clinicians, but even more important for the patients at home that are trying to make their own individual healthcare decisions. So here you can see that the healthcare decision makers are all very busy. You can see that the parents up there are all very busy, and then the physicians have a lot of things to do. Tumors need to be removed, goiters need to be shrunk, and they can't spend the 7 hours a day that they need to be able to keep up with all of the literature that currently comes out each day. So if a study is conducted and it falls into a journal and no one ever reads it, did it make an impact? And even more importantly, if information that is not the best quality information is getting magnified by manufacturers or zealots or powerful people at the exclusion of other, better, more compelling information, then these doctors aren't going to be able to do the best that they need for their patients. So what do? Here's 150 studies looking at a natural product. You go on the websites that are selling the natural products, and you can see that there's one or maybe two of these studies that everyone is always quoting on all of these sites. But the problem is that maybe it doesn't represent the full totality of all of that information, so you think that it's perfectly safe, you think that it's highly effective, but that may not be the reality. If you had gone through and read all of the studies that the doctors don't have the time to do and that the patients don't have access to, the time to do, or the skills to be able to do, you may make health decisions that are not the best decisions for you. So what we do is we take these 150 studies, we come up with the overall pooled effect, we reconcile conflicting information, we find out what the overall strength of the evidence is it strong enough to be able to make a healthcare decision, and then look at the applicability of that evidence. Who does it apply to, and who does it not apply to? By reading this one study, clinicians, healthcare decision makers, and by taking the information and going directly to the news media, we can end up impacting patient care through a variety of different ways. Sometimes we do these reports as a result of some of the work we're doing in the Evidence-Based Practice Center. There's 13 evidence-based practice centers in the United States that is designated by the Federal Agency for Healthcare Research and Quality. We do projects that end up having impact on guidelines that come out for national practice among physician groups. We do things that end up impacting, doing things that end up impacting the development of performance measures that health systems end up getting rated on, and coverage decisions. That means that there's very powerful interest on both sides when you end up doing a project. You do a project and you find out that this new technology is fabulous, that it should be paid for. Well, the insurers are upset at what you did. You look at it and you say, well, this isn't really much better than what's already out there, even though it's very expensive. The manufacturers are very upset. So no matter what project we do, at least one powerful interest hates the project that we did. Usually the other side really, really likes it. And the problem is that most people in the middle who have less of a vested interest, end up being the people that benefit the most from it. So let me tell you an example of a time where we came out with something where powerful interests on both sides both hated it. And that being the result for this slide. So we were asked to put together a panel from people from the American Academy of Neurology, from the Epilepsy Society, and from the FDA to reconcile a very important problem. The problem was that the neurologists and people in the epileptic community were convinced that generic anti-epileptic drugs were no good, and that everyone should be allowed to have brand name drugs, and that everyone should be required by law to pay for it. The FDA believed that generics were equally as good as brand name products, like it had been shown in many other diseases, many other drug classes, and that we should not have any exceptions, that generics are the way to go. So we did that evidence review, and in this evidence review, we found out that when you start a generic or you start a brand name in patient populations, the data was very clear. They are equally as effective. Well, this is going to make one side very, very unhappy. But then we saw that when you switch from one to another, from a brand to a generic, or a generic to a brand, or between two generics, that in the next 2 to 3 weeks, you're more likely to have a ride in an ambulance. You're more likely to go to the emergency department. You're more likely to be hospitalized due to the instability that was created as a result of those changes. This doesn't happen in most drug classes, but the anti-epileptic drugs have such strange pharmacokinetics that even really, really tiny changes in the delivered dose or the way it's delivered can have important impact. So even though both of those people ended up not liking it because it wasn't what they wanted when they went into it, many states looking at this type of data, including Connecticut, now have a ban on automatic generic substitution for anti-epileptic drugs. People like to take dietary supplements, and people are convinced that the products must work better because they're natural. And we found over the years, looking at many different natural products for cholesterol reduction, for blood pressure reduction, that these products are promising. But we've also showed some that are almost all hype. And if anyone has CBD-containing brownies and you're sipping on your CBD seltzer, you're falling into that hype. Okay? Some products are actually downright dangerous. So we started a series of projects where we ended up taking pharmacy students and medical students, and we gave them different natural products. And we measured what happened to their blood pressure and their EKG, because every prescription drug, before it's allowed to be used in any patient whatsoever, has to pass and have not dangerous EKG effects and not dangerous effects in blood pressure. But you have natural products that are being used by tens of millions of people that have never been studied in anybody for their blood pressure and EKG effects. A lot of them ended up passing. But we did one looking at ephedra-containing products. And when we presented those results at the American Heart Association meeting, and we ended up coming off, there were 3 people from the FDA. And they said, we need you to send us all of your EKGs. We need to send all of your original data to us. And so we sent it to them, and they said, don't do anything until you hear back from us. So we sat around and we waited. The meeting is in November. In December, they said, we want you to send this to the Journal of the American Medical Association. And we said, well, it doesn't have so many people. The follow-up wasn't really long. I'm not sure that JAMA wants to take it. And they said, we want you to write this up, and we want you to send it to JAMA. On the day that our paper came out in JAMA, the FDA ended up announcing that ephedra was being banned from the U.S. market. Our project ended up letting them be able to get a subpoena where they had gotten the phone records from the companies that were selling ephedra-containing products, and they showed hundreds of cases of strokes, of heart attacks, and arrhythmias that were not being disclosed by those companies. Kratom. There is a product right now that is an opioid that you can purchase without a prescription. If you were 7 years old, you could buy this out of a vending machine in several different states. Sounds crazy. The DEA tried to ban it, but dozens of legislators in Congress ended up writing letters saying, don't ban it. The FDA believes that it's ineffective and that it's very, very dangerous and should be removed right away. The American Kratom Association believes that it is very effective and it is safe for you to use as coffee. Those are the only 2 powerful interests that have the ability to reach other people, and they're hearing that it's either really, really bad and it's going to kill you immediately, or that it's as safe as coffee. So we ended up doing a review of Kratom, and what we found is that Kratom is a very addictive substance, both for the patients that are taking it or after delivery for the newborn babies that end up getting cut off from their Kratom supply. But when you look at its efficacy, or if you look at the data behind trying to say that it's dangerous, so the case reports, there is so much confounding. There's so poor data that at the end of looking at this, I had to go home each night and wash my eyes out with soap because of the stuff that I had to see. It's impossible for the FDA to be able to attribute a lot of the adverse effects that they say that Kratom is causing because the data is so poor. It's also impossible for the American Kratom Association to say that this is an effective product for doing anything. because the data is so poor. Its pharmacology is very promising, but the reality may not be in line with that. So why get involved in this anyway? Why be involved here? Well, if they take kratom off of the market, now that it's so hard for people to be able to access opioids, we may be taking hundreds of thousands of people and forcing them into a position where they have to buy heroin or they have to buy illicit fentanyl in order to be able to maintain their opioid addiction, where now maybe they're being stable on using this product. But if we continue to do nothing and we leave it in this limbo where it's not a natural product, it's not a prescription product, but it's available to be sold in the United States, what's going to happen? We're still going to be in a position where teenagers that are on a football team who have minor ache and pains are being told that they can go out and get this product instead of taking Tylenol, instead of taking ibuprofen. People are being told that it can do all of these amazing things that there's no proof that it can do. And once you start taking it for a long period of time, what the data does show very clearly from Southeast Asia and here in the United States, it's very difficult for you to get off of it. So this is something where you can make a choice one time, and that choice can have lifetime implications. Somebody had to be involved. Luckily, the University of Connecticut has given us a lot of support over the year, helping us to be in a position to become an evidence-based practice center. For the people in the School of Pharmacy and InChip who are part of the core team that do the methodological work, I thank you. Throughout UConn Health and UConn stores, we've had nurses, we've had physicians, we've had pharmacists, and a lot of other scientists who have formed our scientific advisory committees to allow us to be able to have some of the insider knowledge of what you need to know to be able to do this kind of work. UConn Communications has worked tirelessly to be able to get the stories that have good, important patient care implications and try to get it out into the news media so that they can directly have that information. We would not have been able to go on the Dr. Oz show to talk about kratom if it had not been for the good work of UConn media relations. So with all of us working together, I believe that we do have high hopes going out into the future. Thank you for attending the session today, and thank you.